afternoon. My name is Hervé Bonnefoy from Bordeaux, France. Would like to welcome you on behalf of my co-chair, Kent Osborne, and not Meredith Reagan, of course. The first speaker is my good friend Stefan Aebi, who could give this talk in French, Swiss German, English. Make your choice, Stefan. And it's, of course, a very important talk to introduce this afternoon. Thank you very much. We will ask a few questions at the end of your talk and after the other talks.
Right.
Thank you.
Thank you. Good afternoon. Thank you for staying here so late with this beautiful weather in a beautiful city. Thank you to the organizing committee for inviting me to substitute for Professor Johnson, who cannot be here today. So I've taken the task of trying to sort of remind you of the discussion of yesterday, because much of today's topic has been discussed yesterday. Anyway, we'll talk about integrating multigene signatures in the management of patients with early breast cancer. You've seen my potential conflicts of interest. I don't have any relevant in this topic. So this is going to be what we talk about. So let me set a stage by saying that we'll talk about prognosis and prediction. We want to identify patients with a very good prognosis in order to avoid unnecessary therapies. And traditional tools and factors are, of course, staging, are, of course, grade, proliferation, indices like the Nottingham Prognostic Index or NHS Predict. We also try to address prediction. We'll try to identify patients who are unlikely to profit from therapies so as to avoid useless treatments. And again, we have classical examples like the absence of ER and PR that will predict for the lack of efficacy of endocrine treatments. And there are other examples around. And of course, we'd also like to identify patients who will profit from any particular therapy to use effective treatments. And here, HER2 expression is one of the traditional examples. So we need to move beyond that. 2 years ago, the consensus paper stated that there was no role for multigene signatures in clinical low-risk cases. So that's not my wording, that's just copied from the consensus statement. That a number of gene expression signatures served as prognostic markers, and the consensus endorsed assays for guiding this decision on adjuvant chemotherapy in node-negative cancers, and the principal role was to recommend for or against adjuvant chemotherapy. So that's a quote from 2 years ago. Let me start by giving you a few hints about who does not need the integration of multigene signatures. Of course, patients with tumor characteristics or patient characteristics that do not match the validation cohort of the respective multigene signatures, they do not need integration because they do not need the multigene signature at all. Or patients with excellent prognosis based on conventional criteria do not need it either. The example I show you here would not have fit into the validation cohort of any study. This is too low a risk, and they would not have been included in TAILORX or any other of these treatments, trials. And again, patients for whom the management decisions will not be influenced by the results of the MGS, they don't need integration as well. For instance, a patient with very severe comorbid conditions will have competing risks that outweigh any potential benefit of additional treatment. So let me just show you a few examples. I cannot be exhaustive in 20 minutes, so you'll just get examples of signatures, the most popular ones. We look into prognosis, we look into retrospective validation studies, You have the 21-gene multigene signature Oncotype DX. It was validated retrospectively in N0 and N1. You had patients with pre- and postmenopausal, ER-positive disease, HER2-positive and negative in the retrospective validations. You have slightly different patient characteristics and tumor characteristics in the 70-gene MGS, MammaPrint, in the 11-gene MGS, EndoPredict, and in the 50-gene, the Prosigna. Again, you see that there are slightly different inclusion criteria for the validation studies, and you need to keep this in mind when you choose a particular test. Of course, more signatures are being marketed. I've just chosen the ones that are most popular in Europe. In the prospective validation, you see that there are differences. For instance, in TAILORX, you have only N0 patients. In the population included in the intermediate risk category of 11 to 26, about 1/3 of the patients were premenopausal, 2/3 were postmenopausal. The situation is slightly different for MINDACT, where you have N1 disease included, and in MINDACT, for instance, you have 1/5 of patients who have receptor negative disease, and most patients have HER2 negative disease in MINDACT. So you see that there are differences in the cohorts that were included, and keep that in mind. There are no prospective validation data for the other two multigene signatures. The integration of multigene signatures does improve not prognosis, but prognostication. The example I show here, you've probably seen it yesterday, is from the TransAttack, where you have a clinical treatment score composed of T, end stage, grade, age, and treatment, tamoxifen versus anastrozole. And this gives you a clinical treatment score, and what you see here is how well the clinical treatment score fits the model based on the clinical treatment score fits the outcome data of the patients. And what you see now in blue is that all of these tests make the fit better, so they add independent prognostic information, and this is useful. So it shows you that it is basically possible to integrate treatment scores, clinical treatments with multigene signatures. One application or a potential application, again in prognosis, not in prediction, is the prognosis in years 5 to 10. This is a reminder of the Oxford overview, where you see that late recurrences are common, even in patients with N0 and N1 disease. And one potential application is shown here, the PAM50, the Prosigna test, was used in the Austrian trial to show that patients with a low Prosigna have a very good prognosis after year 5, whereas the patients with higher MGS scores do poorly or are less favorable in the long run. Of course, it is conceivable that these patients could be the ones who could profit from extended endocrine therapy. I put a question mark because this has not been proven, but the possibility that these patients profit is, of course, much lower. Now, how can we do this? Do we have tools? One tool, of course, is just an intellectual one. We should not extrapolate beyond the validation cohorts. So we need to keep in mind what cohorts the scores were validated on, and we should not extrapolate out of this population. But MGS scores and clinical factors have been integrated into prognostic models. I've shown one example before, and here I show you a few more. The 21-gene MGS has been integrated with clinical factors in the RSPC score. It does improve prognostication. This score is available on the website of the manufacturer of the Oncotype DX score. EndoPredict, the 11-gene score, has integrated clinical information to create a score by the name of EPClin. This too improves prognostication, and similarly, the Prosigna test integrates the molecular score plus T plus N and proliferation. This is an example of how this works. If you have the same population, now again from the Austrian trial, ABCSG8, with just the molecular score, you get a separation of the curves, but if you add T and N, the good prognosis gets better, the bad prognosis patients do worse, so the separation is better, and the integration of T and N stage provides a superior prognostic information. So it is possible to improve on just the molecular scores by integrating clinical trials. We should not forget that the HACC staging tools also do the same thing, go in the same direction, one of which is shown here, and another one example is shown here, where you see that you have an anatomic stage, for instance here, T2, N0, N0, M0 results in a stage 2A, but if the patient has a 21 gene recurrence score below 11, this will transform to stage 1A. So there again, it is, so to speak, independent of any manufacturer, and you see that such multi-gene scores are just beginning to be integrated into clinical scoring and decision-making. Let me go on to prediction. There are only 2 trials that address prediction in a prospective way. I'm not going into retrospective analyses, you've seen these yesterday, but I'm going to say a few things about the prospective trials, namely TAILORX and MIND-ACT. You remember TAILORX. The population were patients with N0, ER-positive, HER2-negative breast cancers, meeting NCCN recommendations for adjuvant chemotherapy. That is important. What were the patient characteristics? 5% of patients were below age 40, 1/4 was below age 50, so 3/4 were above age 50, 2/3 were postmenopausal. Most patients had T1 disease, and only 1 out of 7 patients had a histologic grade 3. So most patients, 3/4, had a clinical low risk. The intervention was a randomized non-inferiority trial of endocrine versus chemoendocrine therapy in patients with this intermediate risk group, and you've seen this graph before. There's no difference between endocrine therapy and chemoendocrine therapy. But I'd like to go a little bit more into detail. And what were actually the events? What was the endpoint? The endpoint was invasive disease-free survival. The events included invasive recurrence, second primary cancers, and death of any cause. Now, if you look at all the events that happened, you will see that almost 50% of the events that contribute to this endpoint were contralateral breast cancer and other secondary primaries. So these 2 events are unlikely to have been influenced by the chemotherapy, and they dilute a potential effect of chemotherapy. So for TAILORX, we had the low-risk population. A substantial proportion of IDFS events are not affected by chemotherapy. Now, clinically, does this matter? Does the dilution of the chemotherapy effect matter? And my answer is probably not, as long as the patient corresponds to the average patient of the trial. However, in addition to speculations we've heard yesterday about younger patients potentially benefiting from chemotherapy as maybe an effect of premature menopause. It is also possible that younger patients had fewer second cancers, and this could make the effect of chemotherapy more visible, more easy to detect. So as long as your patient corresponds to the TAILORX population, it doesn't matter. But if not, you should be aware of this limitation. Because enrollment criteria of TAILORX required meeting NCCN guidelines for recommending or considering chemotherapy, more than 80% enrolled could have avoided chemotherapy. MINDACT was very different. This study tested actually the test, and it was not a non-inferiority study for a particular patient population. So you had two classifications. One was clinical, one was genomic, and patients in the discordant groups with high clinical risk and low genomic risk, or high genomic and low clinical risk, were randomized to treatment according to clinical risk or genomic risk. And the main findings were that patients with high clinical risk and good 70-gene MGS risk had a 5-year distant disease-free survival of more than 92% without chemotherapy. They had a low benefit from chemotherapy, and the other divergent group, marked here in green with low clinical and poor MammaPrint risk, had no benefit from chemotherapy. So in MINDACT, again, you had a low-risk population, but the primary endpoint is a bit less affected by non-second primary cancer events. Based on the use of the 70-gene MGS in MINDACT, about half of the patients could have avoided chemotherapy. The last point is just a few remarks about many studies of health technology assessment and economic studies. I found this literature to be very confusing. The main limitation from my point of view is that most cost-effectiveness analyses of these tests do not integrate clinical risk indicators. Therefore, you have widely divergent estimates of costs per quali, varying between almost $200,000 to about $40,000, $35,000. And you have the situation that using the 21-gene MGS may lower first-year spending in younger, but it may increase first-year spending in older patients, and the older patients are the majority. So net, it's very hard to know what happens economically. NICE for the United Kingdom recommended 3 multigene signatures as options for guiding adjuvant chemotherapy decisions. The German EPClin was more restrictive. They looked only at the 21-gene MGS, whereas the others were not looked at for lack of prospective data. And they report a hint, in German a Hinweis, a hint, for a benefit to support a decision for or against chemotherapy. So, as a summary, the conclusion is, within the definitions of the validation studies, multigene signatures do provide information about prognosis and the likely lack of benefit from adjuvant chemotherapy. Tools are available for the integration of MGS into clinical decision-making. Future studies may establish new MGS to guide the choice of drug therapies, which we don't have at the moment. And let me go back to the question, who needs it? For my reading, patients need the information if they're medically fit and willing to decide as informed by the test results. So in my practice, I frequently have patients from central Switzerland who say, no matter what you say, I will not get chemotherapy. If that is the case, you need no test. For patients, absolute treatment effects are of interest. So very small absolute effects although a hazard ratio may be whatever, 0.5, are irrelevant. You need to communicate absolute effects. Physicians need it if the patients and tumor characteristics match preferentially prospective study populations. And then physicians need to choose one appropriate multigene test and not two. So it's wrong to use one, not be happy with the result, and do another one. They do not correlate very well, and there is no reason to choose one or another. Healthcare systems could be interested if they, or need these multigene signatures if the appropriate use of MGS serves to inform chemotherapy treatment decisions, and of course mostly to save costs. Thank you. I'll stop here.
Thank you very much, Stefan. We have time for a few questions. I don't see Fatima Cardozo jumping to the microphone, which is quite reassuring. Stefan, in fact, thank you very much for your lecture. You carefully avoided the question of test for all patients or only for a selected number of patients, considering that you are in the box of the populations where this test has been evaluated. Could you comment further on this point? Do you recommend for specific cases where you are not sure, or more broadly in your institution?
Well, it's easier to make a negative argument, to say that you should be really careful and not use this test. For instance, if you have a very young patient, these patients were not in the population, so don't do the test at all. There's no way you could integrate it anyway. You don't know what the result means. So it is much more difficult to say who to include positively. So it's the patients, of course, it's easy to say the intermediate risk patients, but who exactly is intermediate risk? So it's the patients where it's hard to decide on what exactly to do there. It's easy to give examples, but I find it very hard to give a general rule. So.
Oh, yes, Martin, please.
So does anyone know why these multigene signatures have been largely endorsed by our colleagues in the United States and other parts of the world, and why in Europe we are there struggling for their reimbursement? So is that a cultural phenomenon that we are just always very skeptic about well-conducted prospective trials, but that's the situation. So at the moment, I cannot offer MammaPrint to patients in Belgium. It's the same in the Netherlands. And we worked many years to develop the evidence. So what is wrong in Europe as opposed to US and Asia?
Thank you for the comment.
No, the question was for you, Stefan. I'm sorry.
Well, as a citizen of Switzerland, the answer is very easy. Okay.
No, thank you very much. Probably we can go on with this discussion during the coffee break, but clearly it's non-stop. I think there is a part of psycho-rigidity or whatever on the European side. In addition to, well, it's a difficult discussion because, for example, yesterday, Fabrice André made a good point. It happens sometimes. He made a good point. He said, well, if you, in good institutions where you have very good pathological labs, for example, in Milan with Pepe Viale, you clearly don't need very often this kind of test. But in countries where it's difficult to cover all the area, all the country, for example, in France, there are many places where it's difficult. It's a way to have an equal access to care, and that's an important point. So I don't know how to address this question in front of our politicians or whatever, but I think that this question of equal access to care is important and should not be underestimated. Having said that, it's not, still you have to train properly your pathologists and the multidisciplinary teams. A test is not going to replace a good pathological report and a good multidisciplinary team. But we have to be realistic, and that's something we have to think about. I think we are too frileux, reluctant to... Oh, thank you, Stefan, for your answer here.